All right, so good afternoon, everyone, and welcome to today's webinar, Critical Public Health Law and Policy Issues in 2021, the Year in Review, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. We strongly encourage attendee participation, so feel free to submit questions at any time during this webinar by using the Q&A tab on the bottom of your screen. All you need to do is click on that button and send us your question. We'll be addressing them towards the end of today's session. Your moderator for today's webinar is Brianne Schell, a staff attorney with the network's Eastern Region office. She'll be leading us through the rest of today's webinar. So Brianne, over to you.
Thanks, Charles. So I'll go ahead and introduce our four panelists. First, we're going to be hearing from Dawn Hunter, the director from the Southeastern Region office. Next, we're hearing from Corey Davis, deputy director with the Southeastern Region office. Next, we have Jill Krueger, director of the Northern Region office. And finally, we have Brooke Torton, a senior staff attorney with the Eastern Region office. So like Charles said, go ahead and send in your questions as we go along, and we'll address this at the end. And I will go right ahead and turn it over to Dawn.
Well, good afternoon or good morning to our partners on the West Coast. I'm going to share my screen. Okay. And I'm going to kick us off with talking about something that I'm very passionate about and interested in, and that is addressing racism as a public health issue and talking about development and trends for 2021 and what I think we'll see in 2022. So, what does it mean to address racism as a public health crisis? Hopefully you've heard of this before, and we have lots of network resources that I'm glad to direct you to if you would like to learn more about some of the work that we've done in the past year. But addressing racism as a public health issue really means taking a systems approach to impact outcomes for entire populations, right? And we specifically at the network are interested in the role of law and policy in achieving racial equity and affecting health outcomes at the population level. And so in the US, more than 230 declarations have been issued since late 2019. And early in April 2020, there were only 9. And then after the murder of George Floyd, and along with the COVID pandemic and the terrible toll on Black and Hispanic or Latino and American Indian people, we started to see this huge explosion in the number of declarations that were issued. So by November of 2020, there were over 200. And so here we are over a year later. And so the time that I have with you today, I'm going to talk about some of the things that we've seen and what's been happening and what that will lead us into 2022. We have had 28 issued so far in 2021, at least when I checked a few days ago. But I think 2022 is going to be all about implementation, and I'll talk a little bit about what that looks like. But first, I'm going to start with talking about some recent findings from the network racial equity assessment. So we conducted a survey last summer and a series of focus groups in the summer and early fall. And hopefully if you were able to participate in those, and we really highly valued and appreciated the feedback. We're currently working on analyzing and publishing those results. So these are preliminary findings, but there are some key things that I wanted to share. And I'm actually going to move my camera thing because it's blocking my view. Okay, so the first is that over 83% of respondents to our survey said that they agreed or strongly agreed that addressing racial equity was a high priority of their organization. And that's great, right? We have to make things a priority in order to get resources and people to work on them. But 68.6% agreed or strongly agreed that the organization takes meaningful action to address racial equity. So a disconnect between the commitment and the action. And then only 42% agreed or strongly agreed that they had sufficient resources allocated in their organization for racial equity initiatives. So again, commitment is nice, but you need to actually do something and act on that and put money and people and other resources toward making things happen. So some other interesting findings were also that a pretty small percentage of respondents felt that the workforce reflects the demographics of the community served. And we've seen this actually not just in our survey, but in other major public health assessments like Public Health Wins, Workforce Interest and Needs Survey, that the public health workforce could be more diverse, and especially when it comes to leadership positions. 55.2% of respondents said their organization has an internal structure to address racial equity. So that's not bad, but it is important to have an office or position or some structure that helps to make the work happen. And then 31%, just over 31% said their organization allocates sufficient resources for engagement and outreach in communities of color. So you can't say that you are all about racial equity and health justice and not actually put money toward serving the communities that need the support the most and that have been historically underserved and underinvested in. And again, that I just want to emphasize the idea of allocating sufficient resources is a recurring theme, not just in our work here at the network, but in other major public health assessments, workforce assessments. And so one of the things we also ask people to do is identifying barriers to addressing racial equity in their organization. And here you see them in order. And they all are basically at the top related to workforce development in some way. So again, infrastructure, which I've already mentioned, and funding, but also recruitment, hiring, promotion, and retention. So what are you doing to build your workforce and then also keep people? And what are your succession plans and how are you investing in professional development? And what kind of training and education do you offer, not just for future leaders, but for future leaders specifically in health and racial equity? And the reason that I'm sharing this information with you about the workforce is because of this recent report that came out from one of our important partners who's doing a lot of great work, the Institute for Healing, Justice, and Equity, and the Center for Health Law Studies at St. Louis University School of Law. And this is governmental use of racial equity tools to address systemic racism and the social determinants of health. And this one quote I just want to share specifically, I'm going to read it because it's actually really important. Using racial equity tools has directly influenced changes to internal governmental policies and practices, which ultimately needs to happen before sustainable changes in law and policies can be adopted. So you have to do the work internally first as institutions in order to create change, be in a position to create change in communities. And of course, not just going in and doing to or for communities, but doing with. This is a figure from that same report. And I wanted to share this one because I think the report really explores the use of racial equity tools throughout all aspects of operations. And that's what you see visualized here. So that's everything from strategic planning and training and other workforce development related things, which I've talked about, but then also just creating higher level workplace changes and culture changes and ultimately affecting law and policy. And all of these things are interconnected. I would direct you to check out this report. It has a lot of great case studies and also examples and links to different racial equity tools, and specifically looks at jurisdictions that use two frameworks, Policy Link and the Government Alliance on Race and Equity, and looks at how they've been implemented in a number of jurisdictions across the country. Another partner that we have worked with is Salute America. And I wanted to share that Salute America hosts a tweet chat on Tuesdays. On December 7th, they had their Salute Tuesday tweet chat was on declarations of racism as a public health crisis. And what you see on the left side of this slide are some of the topics and questions that were answered. And we participated in that along with many other partners who are also working in this space. But what Salute America is going to be doing is compiling some of the resources and ideas that were shared during this tweet chat and sharing them publicly. So you'll be able to get more examples of local policies and practices, as you see in the middle of the slide here, to promote racial healing and advance health equity. You'll also get examples of specific resolutions or declarations across the country, resources and tools, and some tips on overcoming resistance to talking about race and racism in communities that may be more conservative or more opposed to directly addressing racial equity. The other thing I'll point out is that Salute America also has an action pack. So if you live somewhere where you have your city, county, state, other local government entity, or other organization has not yet declared racism a public health crisis, they have a toolkit that will help you figure out how to do that, gives you sample language and talking points. One of the tweets that I wanted to share that was part of our tweet chat is this one. I really thought it was great and a great framework to share from Harvard Business Review. But this is really about addressing the different levels of racism. So interpersonal, institutional, and structural, starting by identifying that and building consensus around the idea of racism as a problem that impacts public health. And one of the steps they have here is increasing empathy by sharing accounts of the impact that racism has on people's lives. And if you work in the business sector, it's also about creating a business case for racial equity in your communities. And then finally, taking actions that address those different levels of racism. But you have to start with problem awareness. And I love these questions. Do I understand what the problem is and where it comes from? That's where data collection becomes important. And informs our policy making and our decision making in our organizations. But also, do I care enough about the problem and the people that it harms, right? That's a really important question. Do I care enough to take action? And then do I know how to take action to correct the problem? And so these are all things that in organizations you should explore, and we're seeing communities do that. So one of the other initiatives that I want to share with you is Healing Through Policy, Creating Pathways to Racial Justice. This is an initiative of APHA, the de Beaumont Foundation, and the National Collaborative for Health Equity that was issued their first series of policy and practice briefs in October, which you see on the right side of the slide here, that really explore the use of law and policy to affect meaningful change to advance racial equity and health justice. And so I would recommend checking those out if you have a chance for some of the examples from across the country of policies that have been implemented to address racism as a public health issue. So if you've seen me present before, you've seen a version of this slide, which is these are common actions that we've seen in declarations, what communities have said they're going to do or have been recommended for communities to do. And the first and most important is to, again, normalize conversations about race and health and racism and health. Developing racial equity action plans with clear goals and timelines is important if you haven't taken that step. And then engaging communities is one I really want to emphasize. And again, going back to community-led solutions and engaging community expertise. And then you see some other things related to data and funding, of course, which I've mentioned several times now. So I mentioned 2022 is all about operationalizing declarations. And so it has been a year, and I think in a lot of places, they're still trying to figure out what they're going to do. And in the places that have made the most progress, they started their work well before they issued their declarations or had their declarations adopted. So their communities, and you'll see this in the report I mentioned from Institute for Healing Justice and Equity, where there are communities that started doing some of this work, to really deep work on achieving racial equity a few years before, if not in some cases, 10 years before having their declarations adopted. But then a lot of communities, this is a very new concept. So you're going to see work to review and implement policies and procedures, new laws, regulations, ordinances that advance equity. One that I'd like to share is that in the middle and the top, establishing an enterprise-wide equity framework. And what that means is that making equity the way that you do business and not just considering it a task. This is something that you can do even in the context of the pandemic. And in fact, it's something that you should do in the context of the pandemic because it's the way that we approach every aspect of our operations, from internally to our workforce to externally in the communities that we impact. So you'll see, I think we're going to continue to see some efforts to develop workforce capacity, focus on training and professional development opportunities, trauma-informed care, culturally appropriate services, et cetera. Data practices and infrastructure again. So establishing, we're seeing communities establish task forces, offices, and positions to address racial equity or lead health equity efforts. And one that I'd be happy to talk more about if we have opportunity during Q&A, but is requiring legislative racial equity impact assessments. So the last slide I have really is talking about aligning with other efforts. And I share this because I think it's important to think about doing the work of achieving racial equity through a collective impact model and thinking about like actual ways to take action and implement. There's so many frameworks out there and there's so many recommendations. And frankly, there are lots of good ones and there's lots of overlap. So I think we're at a point where we say, okay, now we just need to actually do these things. So you can check out state level COVID health equity task forces, the White House Health Equity Task Force. One of those excerpts is on the right-hand side of this slide. The Bipartisan Policy Commission put out Public Health Forward on the public health infrastructure. And as did NNPHI recently put out some recommendations regarding the public health infrastructure in the US. So check those out and think about ways that you can pull from those recommendations and also align with other partners across sectors who are also trying to achieve racial equity and who are key partners in advancing the health of communities. So that's it for me. And I am going to turn it over to Corey. Thank you for your time.
Great, thanks, Don. Let me just pull up my screen quickly. All right, can you all see my screen?
Not yet, no.
How about now?
Yes, got it.
Oh, all right, great. All right, thanks, Don. Well, I wanted to quickly talk about drug-related harm in the United States and policy approaches to address it. Now, pulling off of Don's great presentation, we need to acknowledge the racial underpinnings of America's drug policy at the federal and state level. So I've pulled out here a couple of historical documents that go back to early 1900s. This is when the sort of modern-ish approach to some drugs used by some people really was starting to get off the ground. Now, it is, I think important to realize that at this point, a lot of this was really just jingoism, really just racism dressed up as anti-drug rhetoric. But, here's an op-ed that was published in the New York Times in 1914 by a prominent physician called "Negro Cocaine Fiends Are a New Southern Menace," right? Same old story. There's a report from the American Pharmaceutical Association, their annual meeting in 1902. Said the association should direct their best efforts towards the absolute suppression of the incoming of opium for smoking. If the Chinaman cannot get along without his dope, we can get along without him. The other group at that time was one of the other groups was Chinese people who were coming to the United States, particularly on the West Coast, and perceived to be bringing this particular drug, smoked opium at the time. So a way to demonize them, get laws passed to hurt them was to go after the drug. And finally, down here, we've got the report from the International Opium Commission, where the report says it's been authoritatively stated that cocaine is often the direct incentive to the crime of rape by the Negroes of the South and other sections of the country. So again, this isn't, these aren't cranks. This isn't, people muttering to each other. These are, in the official documents of prominent national and international organizations, the newspaper of record, and so on. And we'll skip over about 50, 60 years, come to the beginnings of the modern war on drugs. It was really kicked off by Nixon in the mid to late 70s. So here's an excerpt from an article by a guy called Dan Baum, who was just a great investigative journalist and wrote a wonderful book called Smoke and Mirrors. Actually passed away of a aggressive cancer a couple of years ago. But when he was researching this book, he talked to a lot of people, including John Ehrlichman, which those of you who are my age or older may remember as sort of the Watergate anti-hero, right-hand man to President Nixon. Anyway, he's interviewing him about the book, and John Ehrlichman, just says, we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, And then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So, this is something that we all sort of know, but it's always nice to kind of see it coming from the horse's mouth. So that's where we are. That is where American drug policy came from, and that's largely where it stays, right? So what do we think about that? How well is it working? Well, it depends on what you mean by working and for whom. So it's done a really good job of getting people, especially low-income people, especially people of color, involved in the criminal legal system, which is a nice way of saying thrown in jail. You can see here increase in drug-related arrests over time. There is this meme going around. Well, now that certain people are dying, we've adopted a kinder, gentler war on drugs. There is a little bit to that, but it's largely rhetorical. The United States locks up more people for drugs now than we ever have. It has not changed at the brass tacks level. And here you can just see that dramatic increase in people incarcerated over time. You can see the rate of incarceration in the United States stayed basically the same from the 1920s to the late 1970s. This small increase is just reflecting an increase in population. The rate actually went down a little bit. The population was increasing faster than the jail population. This is the war on drugs. So, and obviously, huge racial disparities. You can see the percentage of white people and Black people who report using drugs is approximately the same, but the number of people arrested and incarcerated is much greater for Black people and people of color. So it's doing a great job of destroying people's lives. Is it doing a great job of reducing overdose deaths? We all know that it's not. Here you can see this is just enormous, just stunning, just heartbreaking increase in overdose-related deaths just over the last 6 years, going from about 45,000 in 2015 to over 100,000 in the latest 12-month period for which we have data. Okay, so like I said, there have been a lot of rhetorical changes in coming from governments at all levels. And there have been some actual changes. I'm going to talk about a big one in a minute. But the important thing, I think, from my standpoint, from our standpoint, is to realize that the overall approach has not changed, despite the fact that the opioid epidemic, as the federal government refers to as, has been a declared public health emergency for 4 years now. All of the changes have been evolutionary. There is nothing that's been revolutionary. There is nothing that has been epidemic appropriate. There have been no major breaks with policy from previous administrations that are appropriate to something which clearly is an emergency and has been declared an emergency. So really quickly, a big place that the federal government has changed some restrictive laws is regarding evidence-based treatment. So there are two highly effective treatments for opioid use disorder, methadone and buprenorphine, and the federal government has slightly lessened the restrictions on accessing those medications. We have a webinar on this, and I'm happy to talk about them in more detail later. But despite the fact that they have lessened those restrictions, these two medications that treat opioid use disorder are still more difficult to get than almost any other medications in the country. By law, the law is set up to make these evidence-based medications harder to get than almost any other medications. That's bananas, but that's seen as progress, okay? Really quickly, I want to talk about the example of paraphernalia laws at the state level, okay? So you sometimes hear, and public health people will even sometimes say this sort of as a shorthand, that injection drug use is a risk factor for HIV, hepatitis C, other bloodborne diseases. This is not true, okay? Injection drug use is not a risk factor for bloodborne disease. The risk factor is lack of access to new syringes, right? Those are not the same thing. Also, we've got this fentanyl crisis going on. Fentanyl has contaminated, has poisoned the illicit drug supply really through much of the country at this point. So there are two, obvious evidence-based things we should be doing. One, make sure that everybody who is injecting drugs has new syringes every time they inject, right? There's just mechanical, right? You don't need fancy epi studies to show that, if somebody is not sharing syringes, they are not going to be sharing blood in those syringes, right? It's just obvious. We also now have these very inexpensive, easy to use little testing strips that'll tell you if there's fentanyl in your drugs. Are they a magic bullet? No, but they can help. Some people get a better sense of what's in their drugs, and that's a good thing. We should be making sure that everybody who is using drugs has access to these things. It's just obvious. But because of state paraphernalia laws, access to both of those devices is severely limited in most states. Why? Well, most states have adopted drug paraphernalia laws based on a model put out by the DEA in the late 1970s that basically say anything anybody uses to get illegal drugs into their body is drug paraphernalia, and it's a crime to have drug paraphernalia, a crime to give it away, and so on. And in some states, the penalties for these are quite severe, up to years in jail for a first offense. Okay, so here's the model law. You can see it. DEA, like I said, put this out in the late 70s and then really pushed states to adopt it. And by the mid 1980s, almost all of them did. Well, this is a problem brought on by law, right? And it is a problem to some extent. It can be changed by law, right? So it is clearly not working. Like, there is no public health professional, there is no physician, there is no epidemiologist that will tell you that what we should be doing is making it harder for people to get syringes, harder for people to tell what's in their drugs, right? There's no question that this is bad policy. So we need to get these things repealed, right? So we're back to this sort of evolutionary change at the federal level. The Office of National Drug Control Policy is spending literally millions of dollars to create these model acts on various things. One of them is called a Model Syringe Services Program Act, which would be better than most state syringe access laws, but it still assumes that paraphernalia should be illegal, right? So what these laws do is they keep the paraphernalia law on the books and they make these little carve-outs, right? So you can't have syringes, that's bad, you're a bad person, you're doing drugs, drugs are bad, you should go to jail, unless you were able to make it to our approved syringe services program, from 2 to 5 on Tuesdays, which are the only hours it can operate, because of course we're not going to fund it. Then those syringes, we're not going to send you to jail for them, although we might still harass you and so on. So this can be changed, right? The feds put out that model law. They could go out and publicly say, hey, that was a bad idea. We had good intentions. We thought that was a good idea at the time. Turns out we were wrong. We are causing a lot of harm. We want you all that adopted that law, because we harangued you to do it, to get rid of it. They've not said anything even close to that. Anyway, that's what we should be doing. This is just one example, right? I mean, we could talk about this for hours. Just these, hundreds of different ways where federal government, state governments are, doing very, very minor changes and talking about them as though everything has changed, when in reality it hasn't. We are still living in this regime that says that the first and most important way to address people who use drugs is by stigmatizing them, criminalizing them, and harming them. And, like I said, this is, heavily steeped in racism. It's heavily steeped in classism. And those things, obviously that's a vicious circle, right? We need to address all of those things. At the same time, I don't want to go over my limit here. I have a great little diversion about Alice, but I won't get into it here. I'll just leave you with this. It's a choice, right? Nobody knows the one thing that's going to solve the overdose crisis, and there is no one thing. But we have a number of laws on the books that we know are making it worse. And, the really low-hanging fruit is getting rid of those laws that are actively making people's lives worse, that are increasing disease rates, that are increasing overdose rates. So, it's a good place to start. We don't need to know all the answers to know that we should, not be, not be using the massive powers of federal and state government to harm people because they use some drugs or because they've developed opioid use disorder. Anyway, I will leave it there. I actually have to leave the webinar a little bit early, so if you have any quick questions, I'd be happy to talk about them really briefly now, because unfortunately I won't be around for the Q&A at the end, but you can always email me. All right, thank you for your time.
So there are a couple of questions in the Q&A. So the first one is if you can give kind of a short take on effectiveness of Good Samaritan laws and prescription drug monitoring programs.
Quick take. It's complicated. So there's a fair amount of research evidence on both of these. I was co-author on a recent paper that looked at Good Samaritan laws that seemed to say that some of them don't seem to have much of an effect. The ones that do seem to have an effect are those that provide protection from arrest. So there are a couple of things that happen. You can be arrested, you can be charged, prosecuted. Some Good Samaritan laws only say you're protected from prosecution. You can theoretically still be arrested at the scene of the crime. And, our research there showed that those laws that provide protection right there, right, so that you can't be arrested at all, do seem to be protective of opioid overdose deaths. I think it's something that needs more research. Obviously, those laws are dependent on everybody being aware of them, because the goal there is to encourage people to call 911 or otherwise summon first responders if there's an overdose. So you need to know the law exists. You need to trust that the law will be followed. Police need to know that the law exists, and so on. So, there's a number of things that need to happen. PDMPs, there's a lot of research. Some of it is conflicting. My general take on it is that, well, I don't know. I would say it does seem that PDMPs may have decreased rates of prescription opioid-related overdoses, but probably increased rates of heroin and fentanyl-related overdoses, which fits with my priors and seems to be supported by the evidence. The idea there being, so for those of you who don't know, the prescription drug monitoring programs basically just that providers and sometimes law enforcement and others see what medications people have been prescribed, particularly controlled substances. But there's very little in most states follow-up, right? So you're a provider, you check the PDMP, you see, oh, my patient is getting a bunch of other prescriptions from a bunch of other people. Some providers are just going to fire that patient. And obviously that's going to be bad. You've got a patient who is either in need of a pain specialist or maybe a substance use disorder specialist, and they're not getting that. You're just, washing your hands of them and sending them on their way. And that's where we see that shift to heroin overdose. So, sorry, there's really no short take on either of those. That's as short as I can do.
Great. So there's a couple more that should be actually easy to answer short, and then we'll move along. But one is about prosecutors. If prosecutors using discretion in which cases to actually prosecute is an effective tool. And the second one is if there are any good states as examples that have good drug policy reforms that we could look to.
Yeah, I think that based on my what I've just been talking about, you all may be not shocked to find out that I think that a lot of sort of progressive prosecutors are also more evolutionary than revolutionary. But sure, police and prosecutors have a lot of discretion as to how they enforce laws on the books, and we know that there are huge variations between jurisdictions there. So yeah. That is another sort of like area of low-hanging fruit where folks can, really make real change by, declining to arrest, declining to prosecute, people for drug-related crimes. Good states. I think that Oregon's drug decriminalization, Measure 110, is very interesting. And I think the thing to keep in mind there is, and something I think sometimes gets lost in the reporting, is that the state not only decriminalized some low-level drug crimes, but they're also putting a massive investment, hundreds of millions of dollars, into treatment, into prevention, into social services. And that's, in my opinion, clearly the right way to do it. And excuse me, why, the prosecutorial discretion is, of course, great. That makes a big difference to the person who did not get run through the criminal legal system. But if there are no resources for them, if you haven't funded the public health departments, if you haven't funded, evidence-based treatment and so on, you're not making long-term change. So I think that Oregon is probably the best example at the moment, and will be really interesting to watch and see what happens there, because they're trying to approach the problem on both of those levels, and they're really doing it in a deliberative, sort of equity-focused way with a lot of community participation. So in my view, that's probably the best example at the moment.
Great, thank you so much. I think we'll go ahead and move on to Jill. And we can continue to do questions towards the end for the other panelists.
Okay, folks, I'm having trouble with screen sharing here. I don't know if you can see my screen, but I'll just go ahead and proceed. I'll be talking about legislative threats to public health authority, and beginning. Okay. So early on in 2021, we began hearing from folks on the ground in states across the country about bills that were being introduced in state legislatures that looked different from bills anyone had seen before in terms of the far-reaching efforts to constrain public health authority. Now, of course, admittedly, this was in the aftermath of more far-reaching exercise of public health authority throughout 2020 and early in 2021 than most of us had ever seen. But that said, there was a great deal of concern about what was happening and a need to understand what was happening. So we at the network partnered with NACCHO, with Johns Hopkins University, with the Local Solutions Support Center, with Change-Led Solutions, and a number of other organizations on a report entitled Proposed Limits to Public Health Authority, Dangerous for Public Health, that we released in late May, early June, to address these trends. And we analyzed a number of laws at that point, given the onslaught of hundreds of bills across the country that had been introduced. We determined to just choose a selective and representative set of laws. So among those laws that we analyzed in that report were included Florida Senate Bill 2006, which provided that local emergency orders would expire automatically after 7 days, unless the local governing body voted to extend it up for a total to 42 days. So still a pretty short period of time for a public health emergency. Another law we examined was Indiana Senate Bill 5, which provided that there could be no local emergency disease prevention measures that were more stringent than a statewide measure from the governor. Another bill that we examined was Montana House Bill 121, in which policymaking authority, as well as the authority to appoint the local health officer, was transferred from local boards of health to local governing bodies. Now that might be the city council, the county board, or it might be a board made up of multiple counties. So those are examples of the kinds of bills that we looked at. And by looking at these bills from across the country, what we discovered was that there were a number of legislative trends happening. The first 4 types of trends that we observed were shifts in authority, whether shifts from the local public health agency to another local entity, shifts from the local public health agency up to the state public health agency or the state legislature, so a form of preemption, from the state public health agency to the governor or the state legislature, from the state executive to the state legislature. So there were all of these types of shifts of authority to remove authority from health departments. In addition to that, there was another category that we said was simply outright prohibitions or strict limitations on certain types of state or local public health orders. So having that kind of typology was tremendously helpful for us to begin understanding what was happening. Now, in the report, we were able to make some preliminary conclusions. The initial concerns of those on the ground who had first alerted us about these bills being introduced, we concluded they were right, that this legislation to block reasonable public health measures posed an immediate threat to life and health. That this legislation, which would stop expert public health agencies from leading the response to health emergencies, created unforeseen, although sometimes foreseeable, serious risks to life and health. And we knew this, because we'd already had some of the early legal epidemiology studies showing the benefits of some of these non-pharmaceutical interventions. One of the first studies showing this was published in Health Affairs in August of 2020, showing a lower incidence of COVID cases in those states that had mask requirements in place. So we already knew that these interventions were effective and that blocking the determinations and the exercise of those authorities threatened the public health. We also concluded that this legislation, while one might differ on the policy and the substance of it, there were also concerns about the procedural aspects of much of this legislation. That legislation that stripped authority from public health agencies and the executive branch and transferred it to the legislature, particularly in the ways that it was being done, violated the constitutional separation of powers and undermined effective government response. And by the ways that this was done, I mean things like in lieu of having the entire legislature make a decision about a proposed law, some of these new laws said that a subset of the legislature could make these decisions in an emergency context. And that's simply not the way how our representative democracy works. The third conclusion that we made in the report was that if adopted, and many of those bills had already been adopted by this point, these bills would make it harder to advance health equity at the very time the pandemic was having a disproportionate effect on Black, Hispanic, Latino and Latina and Indigenous Americans. And of course, you didn't have to just take our word for it. I mean, you can expect how the network or NACHO might feel about these laws. But what was striking in what was being painted as a partisan or polarized issue, what was striking was the gubernatorial vetoes in states like Indiana, Ohio, Idaho. And you can't do much better than this press release from Governor Little in Ohio, which stated that Governor Little will veto the bills because they are overly restrictive and handcuff the state's ability to take timely and necessary action to help Idahoans in future emergencies. The bills unnecessarily politicize the state's emergency response efforts and jeopardize critical funding for local governments. The bills violate the separation of powers doctrine and are unconstitutional. So, given that set of bills, the next question, especially for those public health officials and practitioners operating in states that adopted these restrictive laws was, what do we do now? How do we navigate this changing legal environment? And those strategies are still evolving. I offer here, though, a few ideas that we've seen carried out or emerging on the ground. For example, often there's duplication built into, there had been duplication built into the system that had evolved over time, such that in some instances, it may be easier for a health department to act. In some instances, it may make more sense, or based on the facts or the political or cultural environment, it might be easier for a school to act. So in states that changed the very definition of isolation and quarantine in the state law, states like Ohio and Montana, we saw health departments quickly shift and working closely with their local school districts to make sure that those school districts understood and could exercise in an informed way their exclusion authority of students reasonably believed to have been exposed to COVID. We also saw a lot of creativity and humor, which can be really powerful when there are cultural divides. So for example, in Texas, we saw school districts that were prohibited by the state from adopting mask mandates. Those school districts adopted masks as part of the dress code. Now, a less in-your-face and more strategy came forward in Montana, where the Montana Public Health Institute created tools to support dialogue, constructive dialogue between local public health departments and local government bodies. Now, one of the really important and powerful observations that the public health leaders in Montana made was, our state laws have been changed to limit our public health authority, but our duties as public health officials remain unchanged. And they decided to make that one of the cornerstones of future dialogue. And that may be applicable in other states. That might be an important foundation in other states as well. We're continuing to see strategies around federal funding that are emerging. We're also seeing the emergence, an example I saw was Nashville has recently issued a report on the COVID response. In public health, we might think of this as an after action report, highlighting successes and challenges, including legal challenges. And having that report can provide an opportunity to talk about the legal challenges and the importance of maintaining strong public health authority. Now, it's not, there's certainly plenty to point to that would cause your hair to be on fire. But at the same time, there have been some legislatures that have passed bills to strengthen public health authority, and I wanted to lift up some of those as well. There have been multi-year efforts in Massachusetts and Washington and Oklahoma to strengthen funding and resources and technical assistance for shared services, for regional efforts to protect public health. And those came to fruition in 2020 and 21, or at least partial fruition. We've seen a number of states, New Mexico through legislation, and Indiana more recently through a gubernatorial executive order, establish task forces and commissions to examine the COVID response or to examine public health infrastructure more broadly, which is critical to have those conversations perhaps outside the heat and glare of an active legislative session. We've seen states like Colorado and Florida adopt provisions for increased transparency and accountability, which can help combat disinformation and misinformation. Now, since the Nature report, I think part of the story of the latter half of 2021 is certainly in the emerging federal response, particularly through worker vaccination requirements. Of course, that has sparked its own backlash. Certainly, we're seeing many lawsuits making their way through the courts. We're seeing strategies around the acceptance of federal funds or the refusal of federal funds, and sometimes the creation of double binds where federal requirements are inconsistent, where state requirements are inconsistent with federal requirements, and we'll see that wind its way through the courts and be resolved either through the courts or through continued legislation. So one of the things that we're doing at the network in collaboration with many of our partners is trying to get a handle of what's continuing and what's changing from what we saw when we issued that Nature report, from what we saw in the legislative sessions in the spring. So we're seeing, and one kind of nutshell example would be in Tennessee, where there was a special session to address COVID. And we saw a number of provisions in SB 9014 and HB 9076. Some of those provisions looked a lot like the provisions in the spring. For example, a provision in HB 9076 saying that during a pandemic, the governor has exclusive jurisdiction to issue executive orders. So one of those shifts in authority. But we're also seeing more nuance than we had seen even in the beginning of the year in some of the bills. So that, for example, certain entities are barred from having proof of vaccination requirements unless there are certain severe, barred from having mask requirements unless there are severe conditions prevailing. We're seeing some new provisions where those bills set forth, the Tennessee COVID Omnibus sets forth conditions for schools to require masks rather than simply barring schools from having mask requirements. Interestingly, we're seeing some states adopt, and we saw Tennessee adopt, this strategy that public health championed of addressing the economic impacts of the COVID mitigation measures. Now we're seeing in the Tennessee bill, unemployment benefits being protected for those who lose their jobs because they failed or refused to become vaccinated. So we'll be watching those closely because that will help inform our efforts in 2022. And I'm just going to wrap up in the next minute or two discussing some of what we expect in 2022. We're collaborating with a number of partners at the network, and hopefully those of you listening to this webinar and other partners in our audience to really keep track of what's happening with public health authority and not simply monitor, but advocate for these effective public health interventions. One of the things we'll be doing in addition to webinars, we do hope to host an in-person summit, COVID conditions permitting, in April, 25th to the 27th in Baltimore. We're beginning the planning for that summit. We'd be eager to hear from you either in the Q&A or following through an email, just what kinds of things you might be looking for in a summit of that nature. Other than that, I'll hand things over to Brooke.
All right, thank you, Jill. Let me get my slides up here. All right, thank you. So today I'm going to be discussing an issue that pairs really well with what Jill discussed, and these are existing protections that exist at state law for public health officials. So we heard from Jill a little bit about the attacks that we've seen on public health authority. But on a similar topic, and in that same vein, really, public health officials are not just having their authority stripped or limited or modified in some cases, but they're also on the receiving end of threats and harassment, sometimes to such an extent which it's impacting the ability to do their jobs. So the network, we were contacted by many partners over the first 3 to 6 months of the pandemic. Last year, we were hearing quite a bit about these threats. And so we responded with initially looking at what protections might exist. So at the time, I created a 50-state survey, which would address whether there are laws that deal with threatening, harassing, interfering with government operations at the state level. So we looked into that and I completed some resources. Most recently, we began working on and are close to completion of a few different types of surveys. And these involve doxing and the use of technology as a way to harass. And so we're working on some of that as well. So I'm just going to kind of walk through some of these resources and discuss what's coming and what's going to be available in hopes that this could help some public health officials out there recognize what might be available to them. So the first set of potential protective laws. These deal with threats and interfering with government operations. So I identified these at the state level. I'll talk more about that momentarily. And I also created fact sheets that provide more detail for each state which has such a law. Those are available at the network's website now. And I'm updating them with some more recent links, and they'll be released in the next month. Doxing deals with publishing personally identifiable information and for the purpose of harassing an individual or really encouraging or allowing others to do so. So we are in the final process of editing fact sheets and completing a 50-state survey, which will address what this looks like in the states that have such a law. Technology and harassment. So this deals with usually using a phone or using an electronic device like a computer to harass another person. And so we've looked at states to examine what types of laws they have there. And we are getting close to completing, again, the same fact sheets and a survey, which will be released in the next month. All right, so the first set of laws that we looked at, this being about a year ago, threats and interference with government operations. These are the 4 types of statutes. I'm going to get into some detail for each of these, but really they neatly kind of fit into these 4 buckets, these 4 categories. And so that's how I have found it's most, it's clearest and makes most sense to explain to people what these look like. So 35 states and DC have one of these statutes. I've listed them here for review. Of these, all but 2, that being Louisiana and Oklahoma, would apply to state and local officials. Louisiana and Oklahoma included language such that it was a little narrow and didn't quite extend to local officials and just included state. In these remaining 15 states, these do not have a law that would extend to public health officials. It doesn't mean they don't have a law that protects some government officials. It just means the definitions, the terminology used, it was not broad enough to encompass public health officials. So my home state, Maryland, for example, we do have one of these laws on the books, but it doesn't include public health officials. It includes only certain government officials at the state and local level, but not public health officials. And that was the case in many other states as well. Okay, so before I get into what each statute does, what it means, I just want to emphasize that the terminology used the definition section, which apply to each of these statutes, they really dictate who is covered and what is covered. So like I said, how government is defined in these statutes really matters. Louisiana and Oklahoma, they only included state government actors, but most of the other, or all of the other states really, they included language like government would mean a county, a municipality, or a political subdivision. And that's how I knew that this would extend to all forms of government outside of the state level. Then government function. So what does it mean to impact or interfere or obstruct a government function? Generally speaking, those definitions look something like any activity, was really broad, any activity that a public servant takes on behalf of their government, or is within their role or responsibility as an employee of the government, something like that. Public servant, public official. So this also really mattered. This is how we had to be really careful about looking at what this meant for each state, because this is how we could tell whether it would apply to a public health official and not just a government employee generally. So we're really careful in identifying this and then including that relevant information in the survey, as well as the fact sheets that we created. Okay, so the first kind of bucket of category here, obstructing government operations or public administration. And so what this looks like, this was when a person obstructed, impaired, they impede, or they hindered a public official or public servant's official duties by means of intimidation, physical force, or attempted, threatened, or actual violence. And so the action here, there must have been some type of force, some type of intimidation, or some type of attempt here at actual violence. The impact is that that action had to have actually obstructed, impaired, impeded, or hindered a public official, public servant, or public employee's official duties. And of those 4 statutes, this one occurred most frequently. There are about 20 out of those 35 states that had something that looked like this. And so I took the elements of the statute. It looks slightly different state to state, but I've kind of cut and pasted and combined here what I think would look like a model statute. And these states, their law looks something like this that you see here on the screen. The most common penalty was usually about a year incarceration and a $1,000 fine, though there was a range there as well, 30 days to 2 years in jail and $50 to $6,000 in fines. Right, the second category, threatening, harassing, or intimidating a public official or public servant. So a person threatens, harasses, or intimidates a public official because of their employment or with the purpose of influencing their position. So the action here is the threatening, harassing, or intimidating. The impacts, it didn't have to actually influence a public official or public servant decision. It just has to be that that action was taken with the attempt or the goal in mind of influencing their decision, or the attempt to frighten, harass, threaten, intimidate. In a handful of states, I think it is 9 states have this law on their books. The third, a person, or I'm sorry, not the third. This language here, I want to show you what it looked like from state to state. Like I said, they look a little different, all of them from one state to another, but generally speaking, they look something like this. Most common penalty, up to a year incarceration, and most commonly the fine was about $5,000, though there was a significant range, 6 months to 10 years, or $1,000 to $10,000 in fines. All right, now on to the third. This statute, sort of, I want to call it like the everything but the kitchen sink. This kind of got at trespass or interfering with government operations or public servants, really at government-owned property. And so the impact, the action and impact here is that there usually has to be some kind of restricting freedom of movement to and from government-owned premises, impeding the performance of duties at that location. And so these statutes look quite different from one another. But here, the goal was really, it was to walk and balance a fine line, I think, of allowing people to exercise their First Amendment right. Sure, they can protest, but to actually shut down and impair the operations at a government-owned facility is quite another thing. And so generally speaking, I've combined the elements of those 3 states, and they look something like this. Okay. Most common penalties, we're looking at 6 months to a year in jail and $500 to $2,500 in fines. All right, now the fourth type of law. Only 4 states had this. It's when you obstruct a person enforcing a health law or health officer in the performance of duty. So this was the only one of the 4 that dealt with health law, health officers, health measures specifically. The other 3 dealt with public officials generally, but the ones I included in the chart were broad enough that they would certainly encompass public officials. This is specific to public health officers and those enforcing those measures. And it's a specific crime in which a person obstructs or interferes with a health officer or person enforcing those laws. So there has to be a targeted action or effort at a person because they're enforcing those laws. And it had to have actually obstructed or interfered, not just the attempt. And here's what these looked like. There were some similarities between these 4, but generally speaking, this is what a statute might look like. Incarceration looks like 90 days to a year and fines $200 to $2,000. All right, so now getting into some of the more recent work that we're getting close to completing alongside or partnering with the Johns Hopkins School of Public Health, working on some of this. So doxing. Doxing is when someone electronically publishes personal information about another to reveal their identity with the intent to harass, alarm, intimidate, abuse, or frighten that person. Over the past really almost 2 years at this point, this is one of the major issues that we are seeing public health officials deal with in politically charged Facebook groups. People are like finding and posting personal information, and it's sort of encouraging others to go out and harass that person, contact that person outside of their normal business operations. It's actually not so common that we find these types of laws in a state. Only 13 states have a doxing statute, and I've listed them here. Of these 13, all but 1, and that's Minnesota, apply to public health officials and potentially others. In Minnesota, their statute applies exclusively to law enforcement officials. In Kentucky, the statute permits a civil cause of action in addition to criminal penalties. And then in Nevada and Oregon, the statute only permits a civil cause of action, no criminal remedies there. So I just want to say, even though only 13 states have a doxing statute like this on the books, it doesn't mean that there isn't some other type of remedy at law that is not expressly authorized by statute. There are torts or civil causes of action that one could, hire an attorney and discuss with them, something like, intentional infliction of emotional distress, or there is a tort that deals with public disclosure of like a private or personal fact. So there are potentially other options, even though it isn't expressly called for by way of state statute. And so here, the terminology, it really will dictate what's covered. Most of those statutes cover all persons, not just some type of government official. And what they cover as far as what's prohibited in publishing, it was really broad. There were some differences in the statutes, but generally speaking, they do a great job of covering every possible type of piece of information about a person. And same with electronic communication. It's defined very broadly that it's really hard to imagine another type of electronic communication or device that must be used here. These statutes they've been enacted in like the last decade or so. So they've done a great job keeping up with and anticipating what type of technology might be available in the future. So the definitions here are pretty solid. Generally speaking, incarceration looks like 15 days to a year in jail, but most commonly it was about a year. And the fines were about $500 to $2,500, the most common penalty looking like $1,000. All right, and so the last kind of set of laws that we are putting together now, this is a survey where we wanted to look at technology and harassment. And so what this is going to include, it's really a few kind of bucket terms or categories here. So telephone misuse. Many states have a crime where using a phone to perpetuate some type of harassment is actually a crime, and that's separate than just general harassment. A lot of states also have an electronic devices misuse, and sometimes they're so narrow they include everything but a phone, like a computer or some other, sending a message or just an electronic mail, a crime involving electronic mail. But here, electronic devices, it could be narrow or broad. It just depends on how a state has defined it. So we wanted to cover those and show, in addition to harassment, there might be other crimes that are being perpetuated by harassing someone using, generally speaking, a phone or computer. We also included states that just discuss harassment as being a course of conduct that annoys, threatens, or intimidates another, but we only included states that use harassment and in their definition reference electronics or use of technology. Virtually every state, I mean, every state does have some type of harassment law, but not every single state explicitly references technology. And even though they don't expressly reference technology as being a way to harass someone, you could likely show that given how broad those definitions are. There were a few limited cases where we included stalking, and that was if there was something about cyber stalking, or if a state didn't have a harassment law but had stalking on the books. Stalking is so broad that it could potentially include the crime of harassment. All right, so these fact sheets I referenced. For the first set of crimes I discussed, these are complete. I've updated them recently. For the second two categories, we are working on them now. But what they all will include is really just a guide or a way for public health officials to look at it, have a sense of what exists in their state. That being, where is the statute cited? What definitions, what relevant terms here, what do they mean? What penalties? And then a summary, which is just using, real person, layperson language to explain what that law means. We're also including a template response to violators, perpetrators, where we are allowing folks, or we would encourage folks to use this if they felt comfortable, where they could copy and paste into a response to an email or in a Facebook group that somebody might be, committing a crime. And here's what they face by doing so, by either harassing or threatening or publishing private information. So just one type of tool or resource that we hope can offer folks, we can offer to folks in the public health community who are dealing with the circumstances that we've discussed. And here's an example of that template. So obviously there are places where we would have someone insert specific pieces of information, and then the citation to the law would obviously change as well. But here's just an example of what that looks like. All right, and I think with that, I'm turning things back over to our moderator.
Yes, thank you, Brooke and Dawn and Jill. Looks like we lost Corey, but thank you for those great presentations. I do have quite a few questions that came in, so I'll try to choose wisely and get some good ones in. So the first one I'm going to ask is for Dawn. So somebody asked if there was if there were any objective metrics or reliable models or anything that can measure how you're doing on racial equity, whether you've achieved your goals, just how to monitor your progress. If there's anything out there that can be used for that.
Sure, that's a great question. It's one that a lot of jurisdictions ask. So I will say a couple of things in response very quickly. The first is to do the things we already know how to do in public health, which is to track the impact on communities of color over time of whatever metrics or indicators you've selected in your agency or organization. And so that's something we already do. And so a lot of the data recommendations that we see coming out for public health infrastructure are all about how we can improve data collection and use. And that's partly because a lot of jurisdictions don't do a great job of collecting and disaggregating data by race, ethnicity, or other demographics. So that would be step one. Two would be to establish measures to evaluate that are very specific to your strategic planning goals. So if you've ever been involved in a strategic planning process, your way of evaluating that has to be tailored to whatever it is that you're trying to accomplish. So there are models for doing that. One of those is results-based accountability. I'm going to put in the chat a link to the Government Alliance on Race and Equity framework for racial equity getting to results guide. And they talk about racial equity-based RBA as one way to engage in this work. And then I would say in your communities, have communities participate along with the health department, other government partners, and other committed partners to identify specific population level outcomes that you want to monitor. And then again, go back and be able to collect those and have systems in place to allow you to collect the data on impact on populations over time. And then remember kind of what the definition of race equity is, which is where race does not determine our life or health outcomes. That is something that is going to take time to realize. And so you have to kind of monitor, I think, in incremental ways. So I'll paste that GARE link in the chat. And then happy to take more questions on this or provide some additional resources outside of today's webinar.
Great, thank you so much. So I do have one for Jill next. Have you seen anything in the, is there anything in the Build Back Better plan that is going to give state and local public health agencies any additional opportunities, whether that's maybe additional power or maybe some funding? I know that's kind of a difficult question, but it is definitely of emerging interest.
Sure, thank you for that question. And what I would say is stay tuned and we can have that analysis prepared. We did a similar analysis back in June. We produced a fact sheet, and I think I had the link to that fact sheet in the slides on sources of strengthening public health authority. So in that fact sheet, we had an analysis of provisions in the American Rescue Plan Act. And so we can do a similar analysis of the Build Back Better Act. At this point, I haven't completed an analysis like that, but I have seen, yeah, there's certainly funding for workforce expand. I hesitate to begin to try and delineate that at this point. I appreciate the question and would be happy to follow up individually with the requester and make sure that's on our agenda for fact sheets early in 2022.
Great, thank you. So then the next one is kind of Jill and Brooke, whichever one of you wants to take it, or if you both want to add. But we have a question about what specific steps should be taken to reach a level of sobriety and civil discourse related to public servants. So related to the public health workforce, I guess.
I'm not sure. Jill, do you want to start? I kind of want to give that some thought for a moment.
Sure, I was thrown a little bit by the word sobriety and thinking it was a question for Corey.
Yeah.
Yeah.
I mean, is this about communications about public health officials? I think that's what this question is getting at.
I think so. That's what it,
Yeah.
I mean, I guess in my presentation, what I would point to is, that Nashville report I cited, where there's reflection on both, successes and challenges that city faced. I think, to the extent that there can be some honest reflection on those successes and those challenges, and thinking through how to get that narrative out there, that might be helpful. And I also think these commissions and task forces that we're seeing in Indiana, the Uniform Law Commission, I believe the University of Oklahoma is leading an effort. Some of these forums where the conversation can move forward outside of the political arena, but it's a difficult challenge. I think we've all been struggling with it. I mean, Dawn, your own work on building better messages with Jean Matthews might provide resources for folks. But Brooke, if you have, if this pause has given you any opportunity to come, gather your.
Yeah, I guess what I'm kind of hesitating. I'm on several different, or really two work groups to kind of discuss these issues, and we have really I've spent time over the last year talking with groups like this to get a sense of what should be done, what order. And I don't think there's necessarily steps as in a one size fits all. I think certainly what I've really heard thrown around quite a bit is the need for strong partnerships between public health agencies, the communities, and then law enforcement and prosecuting authorities, at least as far as the threats against officials, that piece is concerned. So it's really like a strengthening partnerships, a media campaign. Those are, at least from my perspective, or the work I've done to cover threats and protecting public health officials. Those seem to kind of be the two big, more like preemptive measures that can be taken, and that's really just based on some of my thoughts, talking to groups around the country, and then on these particular work groups.
So we can move on to hopefully a slightly easier question, or maybe not, I'm not sure, but we have had several, and this is for everyone or anyone who wants to answer, several questions about what we can anticipate for 2022, moving on from these same topics, how they will evolve, or if it'll be something totally different. And that's both, aside from COVID, like unrelated to the pandemic, and then also related to like mask and vaccine mandates and the case law that we've been seeing around that. So just anything you have to predict for next year, I guess.
I would just jump in and say these threats against public health officials and really authority, this is kind of an unprecedented issue. I think people didn't quite know what public health, just members of the public, people didn't quite know what public health was, who we are or what we do. And with the wake of this pandemic, it has, people are, well, they think they might know, but they're at least aware of public health, and they're hearing so much about it. So my concern is that, other public health issues are gonna, and those trying to enforce or pass law or policy are going to face pushback for every public health related issue. And so I anticipate that in the coming years, and I would love to be wrong about this, but I think we're going to see public health pushback and kind of clashing with public health agencies and authority on issues unrelated to COVID-19. And I hate to say that, and I want to be wrong, and I want to end on a positive note, but that's really what I would anticipate at this time.
I would just add to build on what Brooke is saying, it's not just the threats to public health officials and public health authority. I also do work in civic engagement. We have attacks on elections officials. We have attacks on things related to racial equity. We just saw Florida, Governor DeSantis is wanting to introduce the Stop Woke Act to an anti-CRT bill. And there's similar legislation, right, that opposes this movement for racial equity. And, I think at a high level, that's about right now what we're seeing, and what we'll continue to see in 2022 is these efforts to preserve institutions and norms that only benefit certain people. And I think, a similar counter movement to say, we need a new way of doing business. I think the opportunity for public health is to say, we don't want to just preserve public health or give more money to public health or, keep officials in place, et cetera. I think we want to have a new public health. What does the public health of the future look like? And given the lessons that we've learned, how do we do things differently? Because we can't just say we want to also preserve an institution and norm. We have to just kind of revisit what are we doing as public health professionals? What are we trying to accomplish? And how do we actually move toward a more equitable future? And what is our role in making that happen?
I would absolutely echo Dawn that. I think that's really compelling. I mean, my biggest fear is the divergence, the division that we see. We had Barack Obama said in a speech, years ago, there is not two Americas, there's one United States of America. But as we look at, frankly, the efficacy of these public health measures, and we see states like Vermont, affirmatively passing laws saying, yes, local governments can institute mask mandates, as we see New York reinstating through executive order a mask mandate, but we see many other states barring mask mandates. And we know that wearing masks saves lives. We are seeing the stark differences in the, frankly, the death rate among unvaccinated persons as compared with vaccinated persons. It's really troubling to me. it's hard to say a blue ribbon task force is what's going to save the day, right? But that said, I think folks are watching this Indiana task force. But even more, I agree with Dawn and would just echo that we need to articulate a vision. We can't be in a defensive crouch anymore. We have to have a vision for what public health is, what it can offer and how it can bring us together. And, sometimes a crisis is a time that makes that space, it's a lot more pleasant to read about it in a history book than to live through it. But I think this is an opportunity to craft that vision, across populations that haven't been included in the past. And that might be communities of color, that might be rural communities. It's got to be inclusive to be durable.
Wow, it must have been an easier question because those were some really great, depressing, but very inspiring responses from all of you. Thank you so much. It looks like we only have about 3 minutes left, so I'll go ahead and turn it back over to Charles to close out. There are a couple unanswered questions, but of course, feel free to reach out to the individual panelists or the network as a whole to get those questions answered or get some more resources. But take it away, Charles.
Great, thanks. And thank you everyone for your participation in today's webinar. And thank you to our panelists for presenting today. Just a few final notes. All attendees will be receiving an email from the network with the playback of this webinar and the slides, as well as a link to our brief webinar survey. And the survey takes just 1 minute to fill out and provides us with some really great insights. You'll also be receiving an email from ASLME with information on how to apply for CLE credits for today's session. And finally, like Jill mentioned earlier, join us for the 2022 Public Health Law Summit on strengthening protections for community health. You can learn more by going to networkforphl.org/summit. So that concludes today's webinar. Thank you all for attending and have a great rest of your day.